I'd like to welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. I'm delighted tonight to welcome a very dear friend of mine and a very dear friend of ours here at the clinic, Professor Eric Santamaria from Mexico City. Professor Santamaria is a professor of reconstructive microsurgery at the Universidad Nacional Autonomía de México. He is an attending surgeon in the Department of Plastic and Reconstructive Surgery at the Dr. Manuel G. Gonzalez General Hospital, as well as the National Cancer Institute. After completing his plastic surgery residency at the Manuel G. Gonzalez Hospital, Professor Santamaria then spent 3 years doing additional fellowships. He spent time at Chang'an Memorial Hospital in Taiwan, and he also was at Memorial Sloan Kettering Cancer Center in New York City. He has been the microsurgery fellowship director for 20 consecutive years in his program in Mexico City, and he has trained more than 40 full-year, 1-year-long microsurgery fellows. He has 2 fellows per year, and almost 100 international visiting fellows from all over the world, including the US. His clinical expertise spans head and neck reconstruction, which you'll hear about tonight, breast surgery, as well as extremity reconstruction. And his research interests include pre-laminated free flaps and perforator flaps. So we're looking forward to hearing about these hopefully tonight as well. Professor Santamaria has written over 45 peer-reviewed articles and 15 book chapters. Eric has been very active in leadership roles, not only in Mexico, but also internationally. He was elected as the first president of the Fuchan Wei Club, and we were delighted to have Professor Wei as one of our virtual visiting professors a few weeks ago. Obviously, one of the most renowned plastic surgeons and microsurgeons in the world. He was also elected the first president of the Association of Latin American Microsurgery, or ALAM, and we were also honored with another lecture a few weeks ago by Professor Alex Cardenas from Mexico City as well, who is the current president of ALAM. Eric also currently is planning the WSRM 2022 meeting as the chairman of that Congress, which was supposed to happen in Cancun in 2021, but it's been pushed back by a year to summer of 2022, and we're already excited about that to go to Cancun for this meeting. Eric, thank you so much for being with us. We're very excited to have you, and we're really looking forward to your talk today.
Thank you very much, Babak, and good morning for people in Asia, good night for people in Europe, and I'm glad to be here. It's really an honor to share my experience with all of you, and I really appreciate this invitation from all the staff from the Buncke Clinic in San Francisco. So let me share my screen with you. Okay.
Great.
So tonight I'm going to talk a little bit about how to maximize your outcomes in microsurgical head and neck reconstruction. And first of all, I think we all know that devastating facial injuries can create a major impact in these patients. Of course, they produce significant functional and psychological disability. So whatever we do to improve these defects is really good for them. Otherwise, we can preclude human interaction. One of the principles of head and neck reconstructions, as we all know, is to restore form and function, and also to consider aesthetic units and subunits. But also, I would say that we have to consider skin color and texture, but also soft tissue volume. Something I'm always concerned is about the donor site, and I think it's really important to try to minimize donor site morbidity. So sometimes we have to decide between using 2 free flaps versus using a chimeric flap, which of course can produce more donor site morbidity. And since we are talking about using free flaps, we have to choose healthy recipient vessels and sometimes to consider interpositional vein grafts. All of these concepts can be depicted in this patient who was he's an actor in Mexico. He does soap operas, and this patient had a laryngeal carcinoma. So initially he didn't want to have radical surgery, so he received radiotherapy, but unfortunately the tumor recurred, and then he underwent an esophageal laryngectomy together with bilateral neck dissection, and he developed esophageal fistula with persistent salivary leak, and that was a time when they asked me to get involved with the reconstruction. So here in this intraop picture, you can see that I had to address the esophageal reconstruction and to replace all the skin, the radiated skin in the neck. And the only recipient vessels that I had was the transverse cervical artery and vein. So for the esophageal reconstruction, I decided to use a tubalized radial forearm flap because I needed a very long pedicle to connect to the transverse cervical artery and vein. And then I decided to use a second free flap that I hook up to the cephalic vein and the radial artery of my radial forearm flap. And for that, I use an ALT flap that also was helped me to monitor my buried radial forearm flap because these were all connected to the same vessels. So this is flow through two free flaps connected one to the other, and this is the view at the end of surgery. Here is our patient several months later without any revision. He's wearing a voice prosthesis, and you can see that he has a good result. And if we look at the donor side scars, well, we were able to close primarily the ALT donor side. And here is the skin graft that we took from the thigh for the forearm. And this is the patient also showing us that he's able to drink and to have soft diet without any problem. So ideally, we should find this. We should try to have this kind of results. Following aesthetic units was described also many years ago, and after that, some subunits of the nose, the lip, the cheek were described by Buncke and Menick. And I would like to also show you the importance of following these aesthetic units. This is a patient who underwent total maxillectomy with orbital exenteration, and from a classification I described together with Peter Cordero from New York City several years ago, and I will talk about that later, we decided to use rectus abdominis myocutaneous free flap with 3 skin islands. One skin island for the inner surface of the cheek, another one for the lateral aspect of the nose, and one for the external skin in the cheek. And here I would like to mention that this is also something important to have in mind, that don't try to address everything with one free flap alone, like we describe also in another paper. Like in this patient, we also use lip switch flap from the lower lip to reconstruct the oral commissure, like you see here. And then you see these 3 islands of our free flap here after doing all the insetting. And this is the final result several months later, where you can see that by using a local flap, we were able to restore the mouth sphincter. This is a mild microstoma, but it's better than having problems with closing the oral sphincter and patients suffering from drooling food and liquids. So this is better than having that problem. And here you see the skin island inside of the cheek, and this is the external skin island. But following the aesthetic units, you can see that you can have a nice result with a patient who is able to go back to social life. Some other important points to consider for preparative planning of head and neck microsurgical reconstruction are, of course, the patient position and which is going to be the surgical approach. Always try to have a teamwork and organize the participant's role. to design the flap preparatively, to consider that sometimes we are dealing with challenging vessels, and always have a B or a C plan. I'm going to talk a little bit about all these aspects. Specifically talking about flap design, I think that nowadays with the use of CAD/CAM, we can have a better planning of our free flaps, mostly for talking about bony reconstruction. For instance, using the fibula or using the scapula or the iliac crest. And that this is becoming more and more popular nowadays, and I think it's a technology that it's available almost everywhere. We didn't learn to do our osteotomies and everything with this technique, but I think for the beginners, it's a good option. I have seen that some people have become very dependent of this technology, and sometimes I question them what they do if, for instance, the tumor grew up and they have to do an extensive resection and a bigger reconstruction, or what about if there are some anatomical variations we're harvesting a flap. So I think it's good to use this technology, but also to consider all those points that I described. And for instance, for mandible reconstruction, it's very useful to do the osteotomies with these guides that they send you from the manufacturers. And this is a young woman who had an ameloblastoma. And for instance, we use a CAD/CAM to design the osteotomies in the fibula. And I think this is a very simple reconstruction if we have this kind of techniques that allow us to have more precise reconstruction, and then the patient receive osseointegrated teeth, and this is the result several months after doing this surgery and the reconstruction. For other more difficult cases like this woman, I think it's also very convenient to have this technology. This is a patient who came from Colombia for reconstruction of the mandible. She had a history of rhabdomyosarcoma on the left side of the face. They also removed part of the facial neck, and she had a radical neck dissection and radiotherapy. They tried to do reconstruction with a pectoralis major flap, and she also has the facial palsy. And you can see that on the left side, she has no recipient vessels that were an alternative or an option for hooking up our free flap. So we had to design the free flap, our fibula, to connect the vessels to the opposite side of the neck on the right side. So we use also this kind of technology to design our osteotomies. And this is the flap after being harvested. We use a little piece of ADM for the condyle. This is the skin island. And here you see the patient at the end of surgery with a nice contour, with a good result. And this is the patient prior being discharged from the hospital. And this is the patient 3 months later. She went back to Colombia, and they're going to do some debulking of the skin island there to improve the contour. And she needs also treatment of the facial palsy that she has. Talking about challenging vessels, this can be due to having a major size discrepancy because the vessels are in a distant location, or they are atherosclerotic or radiated vessels. Sometimes we find out that they are difficult to access, or mostly because patients already had previous surgery, including the use of free flaps. So we have to decide which are going to be the best recipient vessels that we want to use. And I'm going to show you just one example of difficult access for recipient vessels, but also for the reconstruction. This is a young lady who had a cervical spine chordoma, and she had a history of tumor excision and reconstruction previously with a non-vascularized bone graft and an external fixator. And she had a tumor recurrence and bony resorption of the non-vascularized bone graft 1 year post-op. So they consulted me to work together with the head and neck surgeons to do the reconstruction of the cervical spine and to remove the tumor by them. And so we approach this tumor by doing a transfacial split, including the lip, the mandible, the tongue. So we were able to approach the pharyngeal mucosa and to open it and to expose the cervical spine, and then remove the tumor. And at the same time, I harvested a fibula-free flap, very distal in the leg, so I could have a very long pedicle, like you can see here. And I decided to, this is the defect that we had at the end. It was close to 4 centimeters, and we had a pedicle length of 9 centimeters. And I decided to pre-plate my fibula in order to make the inset easier. And then after insetting the fibula, I had to make a tunnel all the way to the vessels in the neck and through the muscles in the neck to reach the superior thyroid artery and the external jugular vein. And here you see, after completing our microvascular anastomosis and the flap, which is pinky and already vascularized with a small skin island that also serve as a monitor. And then we proceed to close the tongue, the mandible, and all the soft tissue in the skin. And this is the patient at the end of surgery and 6 months post-op. And right here you can see our fibula-free flap. The external fixator was left also for several months more, and then everything was removed, and the patient is doing okay now. I know a lot of these cases will benefit a lot from the use of robotic surgery. I think some people are doing this already, especially in Europe and probably some places in the US. Unfortunately, I haven't been exposed to this, but I think a lot of the future of head and neck reconstruction will be on robotic surgery as well. Talking about B or C plan is something important to consider. This is a patient who had again a total maxillectomy defect with preservation or sparing of the orbital contents. And following our protocol, a colleague did a radial rectus abdominis free flap also with multiple skin islands, but he failed, unfortunately. So the patient came to me, and since he already had radiotherapy, he had a soft tissue free flap reconstruction, I wanted to offer him something better. So for the maxilla reconstruction, in this publication with Peter Cordeiro from Memorial Sloan Kettering Cancer Center, we described that the maxilla is a geometrical figure with 6 walls, and each of these walls is very important in terms of the contact with some other anatomical structures. For instance, the roof of the maxilla is the floor of the orbit, and this is the palate, and this is a lateral aspect of the nose, and all of these represent horizontal and vertical buttresses that are very important to have a good reconstruction, including the overlying soft tissues. So with this classification, we describe 4 types of maxillectomy defects, and since these were cancer patients, we use only soft tissue free flaps and the radial forearm flap, osteocutaneous free flap for subtotal maxillectomy defects. But again, in some patients who already received for benign conditions, trauma patients, or patients like the one that I described previously that already received radiotherapy and he has this severe or complex defect, I decided to use the fibula free flap with multiple osteotomies also to reproduce the buttresses that I needed. So this is this piece of bone was used for the floor of the orbit, like you can see here. This was the maxillary vertical buttress, and then all of this is the alveolar ridge. I here used another osteotomy to reproduce the alveolar ridge, and the skin island was used for the external skin in the cheek, the epithelize in the middle for the palatal reconstruction. And here you see our patient just a few months post-op with a good contour. The palate has been closed, and here you see the bony segments from the fibula that I used to reconstruct all those buttresses that I mentioned previously. And this is the pre-op and the post-op. There is some breakdown of our wounds here, maybe due to the hardware, but again, this is something not so difficult to deal to address. In order to have better results, also consider the soft tissue volume. And for this, I think that prefabrication or pre-lamination techniques are also a good option. And nowadays, with perforator flaps, we can do thin and ultra thin free flaps. And in some cases, say things like secondary liposuction is also a good option. This is a little girl. She was 9 years old. She had desmoid tumor, giant cells tumor, which is a benign condition, but it's very aggressive. And she underwent resection of the tumor, and that included part of the anterior palate and also the alveolar ridge here. So this is the defect at the end of the tumor resection. And for reconstruction, I decided to use a double barrel fibula free flap, where you can see that there is a small piece of bone that we use for the piriform area. And this is the alveolar ridge with one osteotomy. And our skin island, after inserting the flap, we use this to close the palate and also to reproduce the mucosal gingiva. And this is an early post-op result with some swelling. But the problem with this free flap, with this skin island here, as you can see, is that it is too bulky. So she required like 3 debulking procedures to have a thinner skin island prior to, and we're considering to insert osseointegrated teeth. But this is the final result after these debulking procedures with a good contour and just wearing dental prosthesis is waiting for her to grow up a little bit more to ultimately have osseointegrated teeth. And this is the post-op result with the prosthesis, and she's doing okay. But again, one of the problems with the fibula free flap, especially for this type of defects, is that the skin island can be very bulky. So this sometimes makes us to place the bone very high, like in this other patient. So it's not good for the insertion of the osseointegrated teeth. You can see that these are really very high. And the other problem is that sometimes the septicutaneous vessels need to be very close to the bony segment. So in order to avoid all these shortcomings of the fibula, we describe the prelamination of our fibula free flaps by using a mucosal graft, especially for maxillary reconstruction, and especially in patients who had bilateral cleft lip and palate, where they mutilated this premaxilla and they came to us with multiple surgeries using local flaps or non-vascularized bone graft, and they couldn't reconstruct this type of defects. So the prelamination is done by harvesting a mucosal graft from the inner surface of both cheek, and we are able to close primarily the mucosa, and we expose the distal third of the fibula, the lateral aspect, by detaching all the muscles that the peroneus brevis and longus that insert here, exposing, going up to the interosseous membrane here. And then we fix our mucosal graft, as you can see here, and we place a little silicone sheet on top of it to make sure that the mucosal grafts are going to get integrated into the periosteum of the fibula and not to the surrounding soft tissues. And then we close the donor site primarily. And 12 weeks later, we go back to the OR, and we're able to harvest the so-called osteomucosal fibula free flap, where you can see that the mucosa takes up very nice. You can see the amount of mucosa that we are able to include together with our fibula free flap. And this is a very long pedicle that we also design in order to reach the vessels in the neck. And here also we are doing some osteotomies in the like some wings in the fibula to be able to do the rigid fixation of the fibula in the maxilla. And I'm going to show you a couple of cases of patients who underwent this type of reconstruction. This is a teenager with bilateral cleft lip and palate, who unfortunately suffered from a mid-phase retrusion of the mid-phase retrusion with severe collapse of the mid-phase. So in these patients, usually the craniofacial surgeons do a bilateral expanding osteotomies first, and then we do the reconstruction of the central part of the maxilla with this pre-laminated fibular mucosal free flap. You can see the severe transverse collapse that she has in the maxilla. And again, these patients usually already underwent multiple surgeries with local flaps and non-vascularized bone grafts. So we decided to use this kind of approach, as I mentioned before, by doing the fourth one, expanding osteotomies and using the osteomucosal fibular free flap, where we also use part of the mucosa to close anterior palatal fistula sometimes, like in this case. And this is the post-op result with the patient already wearing osteointegrated teeth and a definite prosthesis. And this is the kind of restoration that we are able to provide to these small teenagers. And here you see the fibula free flap. You can see all the hardware from the 4-1 osteotomies from the fixation of our osteomucosal fibula free flap and the osteointegrated teeth. And I think that is one example. Again, with perforated flaps, I think that ultra thin and thin flaps are a good option too, especially for replacing extensive soft tissue defects, like in this young man who had a neurological tumor. It was I think it was from the meningeal layers anyway. So he came to us after having this resection, and he had necrosis of the soft tissue and the calvarium. So we knew that we had to reconstruct part of the skull by using a titanium mesh and to cover this with a free flap. And we did a ultra thin ALT flap and connected to the superficial temporal artery and vein. And here you can see that just a few weeks later, after we removed the stitches, he already had a very nice contour that doesn't require any further revision. This is another patient who had a malignant fibrohistiocytoma, and again, he had an extensive resection of the tumor. And for this patient, I use a thoracodorsal artery perforator flap that can also be thinned down intraoperatively to have a very thin free flap. And this is the free flap after being disconnected. And this is the post-op after one debulking procedure, only with liposuction several weeks after the initial surgery. And you can see that he has a good contour. Again, if you are not able to do thin or ultra thin flaps, secondary liposuction can be also a good option. This patient had some burns in the neck, so we replaced all the scarring tissue with an ALT flap, and we did secondary liposuction, and you can see also improvement of the soft tissue contour 3 months post-op. Talking a little bit about reconstruction of more complex defects, I think there are a couple of questions that we always raise and we have to discuss in order to have a good outcome of our reconstruction. I'm not against chimeric flaps. I use them from time to time, but sometimes I prefer to use 2 or even more free flaps. And also we have to consider if we want to do everything on one stage or multiple surgeries, and like I'm going to show you now. This is a very difficult case. This is a young lady who had a fibrous dysplasia. She underwent multiple resections in other hospitals, and then she was referred to our unit with this huge tumor. Take a look at the left eye, the position where it is. She was about to lose visualization with this eye. And this is an stereolithography showing us the extension of the tumor. So I decided we decided to do the resection together with the craniofacial surgeons in our unit. and to do the reconstruction. Initially, these are some other pictures showing you the extension of the tumor, and intraorally there is also some protrusion of the tumor here. So the craniofacial surgeons did the resection, and we planned to do a fibula-free flap simultaneously, but due to the bleeding that she had, she went into hypovolemic shock, and we decided not to do the reconstruction. We did need some transfusion, blood transfusion, and 1 week later we went back to the OR and do the reconstruction with a fibula-free flap, again with multiple osteotomies to reconstruct the buttresses that we require, and this is the post-op result. Unfortunately, she also developed intraoral and nasal fistula due to a communication from this dead space with those two cavities. So 2 weeks later, I decided to use another free flap to obliterate the dead space and to treat the communications that she had with the palate and with the nasal cavity. And this is the post-op result several weeks later and several months afterwards, after some laser depilation of this hair inside. And this is the patient pre-op and post-op with a good position of the eye glove and with a good contour. We also use a forehead flap to reconstruct the lower lip because there was some mild retraction there. So we need that flap also for reconstruction. And these are pre-op and post-op lateral views of the same patient. One of the gifts that we have in Mexico is those that come from the organized crime. And maybe you are familiar with something that happened back in 2015 in Mexico, where 43 students disappeared, but apparently they were captured by the militaries, and then they were apparently killed by the organized crime. And in our unit, we received one of these students who was probably supposed to be number 44, that guy, and he suffered from ballistic trauma that involved the upper lip, the anterior maxilla, the nasal columella, and again in this patient we decided we had to decide between doing everything on one stage or multiple stage. So I decided to, well, these are some lateral views of the defect and some also imaging studies showing you the defect. So I prefer to do this on multiple stage. I used first a fibula osteocutaneous free flap for the maxillary reconstruction. You see the flap with the skinala that was used to resurface also the palate and the anterior gingival tissue. And then on the second stage, we decided to use a radial forearm flap with palmaris brevis tendon to do the reconstruction of the upper lip. And at the same time, we also did some debulking of the skinala and of the fibula. And then I decided to use fan flap for reconstruction of the vermilion. And again, we kept debulking our soft tissue pre-flaps from previous surgery. And this is the result prior to receiving osseointegrated teeth. And for that, we had to do some debulking of the fibula spinalis and to replace it with mucosal grafts also, so that the implantologists were able to insert these osseointegrated teeth. And this is the final result with a good dental occlusion and restoration and occlusion. And here you see the skinala of our fibula free flap. And again, this is the pre-op and the post-op condition in this patient almost 2 years after we start reconstructing him. This is another difficult case. This is also a patient that was referred to us from another state in Mexico. He was injured again by the drug cartels in Mexico. And after he was stabilized and he had a tracheostomy, he was referred to our hospital. And we had to decide whether using one single pre-flap, like a chimeric flap, probably the iliac crest with extensive skin island, or to use multiple pre-flaps. So I decided to use multiple pre-flaps for reconstruction. We did all the preparative planning, again, with this kind of technology, CAD-CAM, and also with stereolithography. And I use, again, a fibular subcutaneous free flap for mandible reconstruction with multiple osteotomies. And then I also use an ALT flap for reconstruction of all the soft tissue in the neck and the cheek, and the chin, I mean. And this is the result several weeks after that surgery. Unfortunately, he developed some salivary fistula, and we ended up with some infection and some necrosis of our ALT flap. But the fibula free flap was okay. You can see here a 3D CT scan showing us our fibula free flap for mandible reconstruction. So after doing some cleaning and waiting some time for this to improve, I decided to do another ALT flap from the opposite thigh, and we use part of the local tissue to reconstruct the chin. This is the second ALT flap for the neck, and this is an early post-op result. And this is the patient just a few weeks after this second surgery, where you can see a good reconstruction of the oral sphincter and the cheek and the neck tissues. This is the pre-op and the post-op result. So I would like to conclude my presentation saying that fortunately nowadays, I think that there is a better understanding of the therapeutic challenge in all of these difficult cases. Fortunately, plastic and reconstructive surgeons are part of the multidisciplinary team approach. Nowadays, we have a superior rigid fixation system, so we can achieve better results compared to the ones that we had like in the late 80s and the beginning of the 90s. With all these new techniques, I think we have improved more our microsurgical techniques. New technology allow us to have a more precise and meticulous preparative planning. And I'm sure with perforator flaps, pre-laminations, and all of these techniques, we have refined our harvesting, the way we shape our free flaps, and the insetting of these composite free tissue transfers. I would like to thank you very much for your kind attention, and please don't forget to come to Cancun, not in 2021, it's going to be in 2022, for the 11th Congress of the World Society of Reconstructive Microsurgery. I think it's going to be a great venue and a great scientific and social program. Thank you very much again for your attention.
Eric, thank you so much for a fantastic talk. I mean, you've really shown the full spectrum of using pretty much all aspects of microsurgery, from skin flaps to bone flaps, virtual surgical planning, and operating in very difficult fields, everything from trauma to congenital to cancer. So thank you for that. I think that unfortunately in the U.S., the head and neck field is more and more being dominated, at least reconstruction, more and more being dominated by ENT surgeons who are doing their own reconstructions now. And so many training programs in the US are now basically not getting as much head and neck as they used to get in the past. Can you tell us a little bit about the landscape of head and neck reconstruction in Mexico? Is this the kind of a similar phenomenon over there as well, or is it still dominated by plastic surgery?
Yeah, I can tell you that fortunately, it's been dominated by plastic surgeons, because it's not like in Europe, for instance, where maxillofacial surgeons are DDS, and then they do medicine, and then they can go directly into maxillofacial surgery, and they do a lot of pre-flaps. That's in Europe. In the US, I know a lot of ENT doctors and also some maxillary maxillofacial surgeons are doing head and neck reconstruction using free flaps. But in Mexico, our maxillofacial surgeons are only DDS, so they don't really get involved with doing free flaps for head and neck reconstruction. So we work together with both maxillofacial surgeons and head and neck oncologic surgeons as well.
That's great. I think, you know, it's such an important part of our field, and it's been a part of our field for so long that it's unfortunate that in the US there's kind of the trends, if you will, are going in that direction. And I think about a decade ago is when head and neck surgeons began training in microsurgery as well. And now obviously as the gatekeepers for the cases, if they do have the capacity within their departments to do the reconstruction, they obviously would like to keep it internalized. I have a question for you about the virtual surgical planning. I think CAD/CAM is a really amazing tool, and we actually had a talk on that by Jamie Levine from NYU about his use of virtual surgical planning, and it's clear that it does offer many advantages to the more traditional reconstruction, which was basically done by hand and by experience. The question I have for you, much like the you know, robotic surgery or using the venous coupler for sewing veins versus hand sewing, do you think that it's almost too easy for residents to rely on virtual surgical planning? Do they still get to learn the traditional technique of doing this in case they don't have VSP, or if they do get VSP, but the intraoperative plan changes and the resection is somewhat different? Can you comment on, obviously you have the experience from the past having done these without VSP and now you use that, but you can still fall back and rely on the traditional technique. Any thoughts on that for new trainees coming through the process?
Well, first of all, I think that technology is something that we have to accept that is really important for us. And in many places, we initially criticize being so dependent on technology. I remember when people start talking about you asking for CT angiograms for planning your DF flaps. Well, a lot of people criticize that. But nowadays, I think everybody is doing this kind of imaging studies to do your preparative planning. And I would say it's the same for this CAD/CAM and all this software that is useful for better planning your free flaps. And I think that it is very important that also our trainees learn how to use the old techniques and to do all the planning without having this technology, because you don't have it available everywhere. First of all,
Right.
especially in developing countries, it's not always available. Even in our place in Mexico City, in some hospitals we don't have it, or it can take a long time to have all the guides for the osteotomies and all the planning. And if you have a patient with cancer that requires a resection like in the next 1 or 2 weeks, probably you don't have enough time to obtain all this information from from asking the company to do it for you. But now, because it's becoming more popular, I think it's also something that people are starting to develop in their own units with not very expensive software and technology. And I think that is a lot of there is a lot of improvement with all of this, and the ultimate, I think eventually it will be accessible to everybody. But on the other part, I think it's not good to be so dependent only on technology, because as I mentioned before, and also you agree with me, sometimes you know, people think that everything is so predictable, and it's not true. You know, you need to be flexible, because sometimes they might be a bigger resection of the tumor, or the trauma requires to remove more tissue that is necrotic, and if you are not flexible, then you can go into problems. That's
I
what I
think those
think.
are great points. Yeah, that's a really good point. And I think with regards to the less expensive alternatives, you're absolutely right. In fact, there was a fantastic lecture by Susana Heredero in Spain as part of the International Microsurgery Club lectures, where she discussed her version of virtual surgical planning, which is actually much much less expensive, which was really interesting to watch. So I encourage everyone to go to the IMC website run by Tommy Chang from Chang'an and check out that lecture as well. And I think part of that is, we still, for example, hand sew all of our veins. I think while the coupler is a great device and it obviously works very well and is very efficient, I think we still like to train our residents in the kind of the older techniques, just in case. I mean, you may be in a place where the coupler may malfunction or you don't have the right size or whatever it is. It's just good to kind of know those old-fashioned techniques still.
Yeah, we do the same. We don't have the venous coupler,
Mm-hmm.
and I prefer to also train my fellows and allow them to do the vein and to practice more. And I think it's part of the beauty of microsurgery. So the coupler is very useful, to reduce the surgical time. But again, other than that, it's expensive and sometimes you cannot have it. But it's also good for practice.
Yeah, definitely. I wanted to ask a question about your dental implants. I think that you showed some phenomenal results from an aesthetic standpoint of reconstructing the mandible. We had as I mentioned, a lecture by Jamie Levine of NYU, and he was talking about the so-called jaw in a day procedure, where for certain indications like an ameloblastoma or something like that, they're doing the fibula and the implants and everything or at the same time. And I wanted to ask your opinion on that and how many of that are you doing, if at all, and what your thoughts are.
You know that I learned that from my fellowship with Dr. Fu Chen Wei in Taiwan.
Mm-hmm.
Actually, we wrote a couple of papers about that, about primary insertion of osseointegrated teeth. And now it's becoming more, that was more than 20 years ago. And now I think now it's becoming more and more popular. And I think it's good if you have all the technology, if you work with prosthodontics and the people who are responsible for doing the insertion of the osseointegrated teeth. I don't do it myself. I send the patients to the implantologist. But I think it's a good option, but the indications are very clear, and we described that already in those papers, because I don't think it's good to use them for patients who have malignant tumors that are going to require postoperative radiotherapy, because the chances of losing the osseointegrated, the implants, are very high, and then you are spending a lot of money, and again, everything becomes a mess. So I think the indications are only for benign conditions like ameloblastoma or benign tumors, also trauma patients or congenital deformities, stuff like that. Other than that, I don't think it's indicated.
Yep. I think that's kind of the general thought of others as well. So I'm glad you agree. The next question actually is completely unrelated to your the specifics of your talk. I was wondering if you can tell us a little bit about your fellowship. I think that a lot of people who are going to be watching this video later, and what I want to do is also just familiarize people with fellowships that are out there around the world. I know you have 2 fellows per year. Can you tell us a little bit about their experience as far as how much they spend in the head, neck versus breast versus extremities and so on?
Yeah, this has been a program that I started already 20 years ago, and it's been a continuous program. And you receive 2 fellows. Usually one is from Mexico and the other one is from abroad. Most of my applications are from people who come from Central or South America, Spain or Italy, and I think that's mostly due to the language. But I've trained people from the US or even from other countries. They come as visitors, and Europe, in Indonesia, other countries like that. And I think they don't really struggle a lot with Spanish, because they are always with my other fellow who speaks both English and Spanish, or many of my patients in private practice, they speak English fluently. In the public hospital, it's not easy. But again, I think it's like when I was doing my training in Taiwan, I didn't need to speak Taiwanese to operate on all of that. But and I think it's a good experience to go to another country and also to try to learn another language. I've trained 2 fellows from the US already. One of them is Rachel Bluebond from NYU now. And I mean, she was very good on learning Spanish, and I think it's also convenient at some point. But again, talking about the how much they do, On average, we do between 150 and 180 free flaps per year. And I would say that in the old times, I used to do more head and neck, but now I do more breast reconstruction with free flaps because, you know, breast cancer is something that more common.
Yep.
That is probably like 40–50% of my practice, breast reconstruction. Another 30% is head and neck, and 20% is mostly lower limb. I don't do any peripheral nerve surgery because I send everything to Alexander Cardenas. And we have another, one of my fellows also did another training in lymphedema surgery, and she is also receiving all patients for that kind of surgery. I don't do any super microsurgery, so I focus only on those three areas: head and neck, lower extremity, and breast. But again, also my fellows work together with, her name is Erika de la Concha, the one who is doing the lymphedema stuff, and they can also have rotations with Alexander Cardenas. So they're exposed to everything depending on what they want. And usually the way it works is that my fellows are at the end of the year are able to do cases by themselves. So for the first 3 months they work as an assistants. I mean, they help me doing the surgeries, so I can have an idea about how much training they already had, and in that way I can allow them to start harvesting the flap, preparing the recipient side, and then doing the anastomosis. But the last 3 months of this 1 year fellowship, they have to do the cases alone, and I of course supervise them and I scrub and help them. But the whole idea is that they be able to do the cases alone. And in the public hospital, for instance, in the National Institute of Gastrology and Heron Salles, they also can operate alone. So there is always somebody supervising, but if they got the chance to do this alone, I think it's really good for them.
Well, it sounds like an incredible fellowship.
It's a learning curve, you know.
Yeah, it sounds like an amazing fellowship, and obviously in an amazing city. So I encourage everyone out there to take a look at it for sure. We're all really looking forward to the WSRM Congress in 2022 now in Cancun. Is there a central theme that you have for this conference at the moment? And sometimes there are certain kind of themes that you would choose. Can you tell us a little bit about that?
Well, you know, as since it is the World Society, we're going to cover everything in reconstructive microsurgery, but we want to focus mostly on all the new stuff that it's coming out in all the journals and in different meetings. You know, I think we will have to include a lot of lymphedema, a lot of imaging studies with all this new technology. You know, ultrasound Doppler, all the new technology that is very useful for preoperative planning and intraoperative planning as well. But I think we want to introduce more new topics, and specifically to have panels where we can discuss controversial issues, and not only comparing what we used to do in the past and what we're doing now. We want to also involve a lot young microsurgeons who are the future of our field, and I think there's a lot of talented people all over the world doing great stuff, and they need a platform where they can present what they are doing and to interact with all the big masters from around the world.
Yeah, definitely. Sounds like a great theme, and I think including all that new technology is a really important, I think, part of our learning. Professor Balakrishnan from Chennai, I see your webcam is on. Did you have a comment or question for Eric?
No question, comment. Just thanks, Eric, for the incredible talk. And it's very important that now we focus mainly on the head and neck reconstruction, which is now in the forefront. The extremities are slowly coming down, and we all have now faced only with head and reconstruction. And we do have a lot of dental colleagues help us in modeling. This 3D modeling is done by the maxillofacial surgeons in our country. Thanks, Eric. Thanks. It was a nice talk, and hope to see you in 2022 in Mexico. Thank you. Thank you so much.
It was very nice to see you, Professor Balakrishnan, and I really look forward to seeing you in Cancun. You are very welcome.
Okay. Good. Thank you.
Thank you for that comment.
Thank you.
Eric, thanks again for being with us. It's really an honor to have you. I miss seeing you in person. So hopefully we'll be able to see you before the 2022 WSRM meeting, hopefully at another meeting either in the US or overseas. So thanks again for joining us.
The pleasure and the honor was all mine. Thank you for the invitation, and nice to see all of you guys virtually. And I look forward to seeing you also in Cancun in 2022.
Great. Thank you so much. Have a great night. Have a great weekend.
You too. Bye-bye.
Bye.